lost Tricia. We lost her in the runs moved in the cafe.
Lost?
Tricia.
All right, you all right?
So it's definitely around there.
That number's the
Well, good morning, everybody. Welcome to Healthwatch Norfolk Live at the Forum. Thank you very much for being here. Hope you can all hear and I hope you can all see. We'd like to thank everyone who's here in person and those who are watching online for joining us today. Healthwatch Norfolk Live is an event we hold on a regular basis in different parts of the county. It gives us a chance to update people on our work, talk about our priorities now and in the future, and work with our partners in the health and care system to share information and to answer questions. This will happen next in the first part of Healthwatch Norfolk Live, when an esteemed panel of health and social care provider leaders will be taking your questions, and you can see them arrayed before you. Alex, our Chief Executive, will then update you on our work over the last financial year and give a taste of what we're working on next over the next 12 months. This is also a special year for us at Healthwatch Norfolk, as we're celebrating our 10th birthday, and to mark the occasion, we'll be presenting some Healthwatch Heroes Awards to people who have gone the extra mile to help us in our first decade, hopefully not our last decade. And we're delighted to welcome one of my predecessors and our honorary president, Bill Armstrong, to present these awards later on in the morning. Finally, I do just need to give you the various bits of housekeeping. If you hear the fire alarm, follow me to the entrance to the gallery over there, because I shall be first out, and where the team for the forum will direct you to the nearest fire exit and fire assembly point. So now we move to the first item on our agenda today, which is the panel discussion. And I'm delighted to say we've had a number of questions submitted, and I will now start the process by reading the first question from Alistair Roy. So, for every £1 invested in information and advice services, £15 to £18 worth of benefits are achieved for vulnerable people who qualify for benefit but have not applied for a number of reasons. The money received is used to heat homes and provides healthy food to enhance people's lives and be less dependent on health and social care services, as well as helping to stimulate the local economy. It can help tackle loneliness and isolation. There is a good working model under the NCAN framework, and it's funded partially by NCC, which is excellent. But for the first time, waiting times are lengthy, and some partners have exceeded their quota enormously. There is no similar service in Waveney, so a large number of vulnerable people are excluded. Will the Integrated Care System, the Integrated Care Board, and the Integrated Care Partnership recognise the value of this service and commit to investing in it as a priority? Tracy, I guess that's fairly and squarely in your court. Can I introduce Tracy Bleakley from the Integrated Care Board?
Hello, is this working? Can you hear me? Is that working?
Yep, I think you're fine, Tracy.
I could probably project anyway. So it's wonderful to be here, and thank you for these questions. The whole purpose, can I just say, of the Integrated Care Board and the system is to work with all the residents of Norfolk and Waveney to improve health and social care and to help everybody live as healthy and happy lives as possible across Norfolk and Waveney. So these events and these questions are really useful. Just a little note on the money, and you've probably seen this in the press this week because everyone's talking about the NHS budget. It is extremely stretched, and it is extremely stretched in Norfolk and Waveney. However, what we want to make sure is that we can invest in the right things. So we've set up what's called a prioritisation process, and we have a wide panel looking at that. And every 3 months at the moment, we're looking at changing the timescale, but at the moment, every 3 months, we put business cases forward of things like this, which we can invest in, we can put more money in, and we look at that in the round against all the other things that we want to spend money on. So absolutely, I completely agree with the gentleman that put this forward. Advice and guidance services, we know they make a big difference. I think the other thing that we can do as well, and this is part of being a system, is we can pull together the voluntary sector and make sure that we're making the right appropriate links there. So my background actually is I used to run Hospice UK. And it was great how we could help people through hospices with their benefits. We could link up to our partners in Citizens Advice. We could link through Mind and Relate. And we could put tailored support around people and give them the help and advice they need. So as well as looking at the money and the prioritisation, and I agree it's really good value for money, I think that there's more that we can do to join up the voluntary sector as well. So very much behind this and welcome the question.
Thank you very much. Thank you. Anybody from the panel like to make any additional comments? I'm looking at you, Ian, for example, from NCH&C.
Or East Coast Community Healthcare.
Sorry.
But it's, I
That's
won't
the
take
one.
it personally. Yep. But so I think we, as East Coast Community Healthcare, we're a community provider that works across the Waveney, the Great Yarmouth and Waveney area. So we're 50% Norfolk, 50% Suffolk, as is Joe at the James Paget. And I think one of the things that we can do, where there are differences between the way councils deliver it in one particular area or another area, is we can be a really useful bridge across that and ask those questions. And I think one of the things that is different about the integrated care system is the fact we have to now look at health and care together and make these kind of balanced judgments. Now, again, with limited money, you can't do everything all at once. But I think the fact that we're getting them on the agenda, that we're using the prioritisation that Tracy's talked about, that we're able to get these really important issues up and discussed so we can take the decisions about it.
Thank you very much. Anybody else like to add anything? No?
So the only thing
Joe.
I'd probably like to add is how we interact, certainly in Great Yarmouth and Waveney, and I know it's in place across the wider Norfolk with the borough councils as well, because it is about those wider determinants of health, housing, and all of those other things. So it's really important that we engage with all of the providers, not just the county council.
Thank you very much. Thank you. And we'll move on to question 2, which again is from Alistair Roy. And his second question is, during consideration of a case study at an ICB meeting, it was stated, if the services provided to those in later life were provided to children and young people, there would be an outrage. What lessons have been learned, and how soon will there be older people and their providers involved in designing new improved services or a later life charter setting standards and values for health and care services be designed for older residents in Norfolk and Waveney? Tracy?
I'm very happy to take that one.
Good, thank you.
Yes, so we consulted last summer on our 5-year joint forward plan, and I was pleased to say that 700 residents put forward their ideas as part of that. And as a result, ageing well is one of our priority areas for the next 5 years. So we've set up an Ageing Well programme board to do exactly that, to start designing services. And we've also started working with Age UK, so Dan Skipper as well, on the engagement side and working with people across Norfolk and Waveney. It is a particular passion project of mine. Having come from Hospice UK, one of the things that I saw was actually there are good services often, but they're not joined up. I remember talking to a family who said that on one day, when their mum was terminally ill, 16 different people rocked up at the front door, all from different parts of the system, all doing different things, whether they were charity or community services, or they were delivering equipment or whatever. They called it conducting an orchestra. So actually one of the big things that I want to see is us all working together. So for the person, they're at the centre of their care, but we as a system are managing all the interactions. So we're actually using every different part of the service at our disposal to help people. I want to see prevention as well. I want to see people get better information, and I want to see people get care in their own homes, and that's a big push for us. So rather than the first thing being, we'll send out an ambulance and you'll go to the Norfolk and Norwich, which is a great place to go, by the way. However, and I know Nancy will heartily agree with me on this, there are things that we can do to keep people in their own homes. If somebody's had a fall, for example, they don't necessarily need to be in the hospital where they may be for several days before we can discharge them. If we can look after those people in their own homes safely, we should do that. Somebody needs antibiotics because they've got a urinary tract infection. If we can look after them at home, it's best to do that. So we're all working together to redesign services. It is a priority, and we are going to be working with local people.
And older residents.
Yes.
Yeah, thank you. Nancy.
So I do wholeheartedly agree with that. Thank you very much. I'm Professor Nancy Fontaine. I'm the Chief Nurse at Norfolk and Norwich. So one of the key areas that we're seeing this, particularly with our older population, is keeping them well when they're waiting for planned interventions. So you will find working with the voluntary sector and our community services, particularly in physiotherapy and occupational therapy, we're trying to pre-optimise and maintain people's function, perhaps while they're waiting for knee or hip surgery. And those sorts of exercise programmes and keeping our local community at their best that they can be while they're waiting and not deteriorating on the long waiting list we've all incurred through COVID has been exceptionally powerful. And I know that because my own mother has used it and told me why, and she is an ex-nurse and we are the worst, I'll tell you. Why hasn't everybody got this in Norfolk? How come there are only pockets? And I think there is lots of learning for us about how we join up pre-optimisation and community services to keep our older population well. Thank you.
Thank you. Ian.
Can I so I, as one of the priorities, I chair the Older People's Board and the Older People's Strategy. It's relatively newly set up, and I think the bit that we're trying to do that's different is when we kicked it off, we had a group, I don't want to call it a workshop because it sounds too sort of management speak, but we had a group of people together. We had 70 plus people that, yes, it had people from medical backgrounds, yes, from care, but also from voluntary, charitable and faith backgrounds, and most importantly, people who experience it, either as carers or people who receive it. And I think that you could kind of say it's blindingly obvious, but the lessons we relearned, I think, is about putting the individual, not the patient, because we over-medicalise things often. So putting the individual at the base of it, at the centre of it, and it's about the coordination of the different assets. So we're trying to think differently about how we can do it. And I think there is a tendency within the health community, certainly for us to look for a medical solution to fix something, where actually the answer is a much more holistic problem experience that the individuals have. And if we're able to join up the services in that way, so it's the connectivity, it's about joining up, it's about us working together and putting the individuals at the centre of it, not simply over-medicalising it and looking to put it into one of our buckets or of our within our boundaries.
Yes.
Hi. Thank you very much for the question, because I think it's a really good opportunity to talk about what is going to be different and how we're going to move things forward in Norfolk and Waveney. So I'm Tricia Dorsey. I'm the Executive Director of Nursing. And what has been described very eloquently by the panel is the right care in the right place at the right time. So we need to look at our services with working with residents, the voluntary sector, our acute partners, our mental health partners, to think about how we can provide those services locally in a much more effective way. Now, I know the question alluded to children and young people's services and, you know, the comparison between the two. I think there is much that we can learn with regards to collaborative working. So from a children and young people's perspective, you already have established relationships between social care, education, health, voluntary organisations, and they come together in an alliance to actually ensure that those services are really provided in the most effective way that they can be. So with the work that Ian's leading, it gives us an opportunity to actually move towards that collaboration, using the best that everybody can provide to address and support people and empower them to remain in their own home and know where they need to go to get services. Thank you.
Good morning. Good morning. Alice Webster, Chief Exec of QE in Kings Lynn, and a nurse too. So you're overburdened with nurses along this one, I think. But just to say, actually, it's really important to look at this from a health perspective, but also from a social perspective. So absolutely all the things we do are underpinned by working with our local borough councils, the county council, voluntary sectors, because it's not always an acute setting that somebody needs to receive the services. And if we could intervene much earlier in a different way, then we might have different outcomes for people. So I think I just wanted to make sure people understood we are going back much further than just that episode of care that somebody may or may not need.
Thank you, Alice. That's really helpful. And we'll move on to question number 3. This is from Dr. Rayner. He says, following the case of the disgraced surgeon Ian Patterson, a number of recommendations were made by the independent inquiry. The second recommendation states, we recommend that it should be standard practice that consultants in both the NHS and the independent sector should write to patients outlining their condition and treatment in simple language and copy this letter to the patient's GP, rather than writing to the GP and sending a copy to the patient. The government has accepted this recommendation in full. Please could the panel explain how this recommendation is being implemented across Norfolk hospitals? Well, we have 3 of our acute hospitals represented here, so I'll just start with Alice. Thank you.
Thank you very much. An interesting recommendation, really, because we need to do some education with our consultants around how they're writing letters. They speak in a very formal medical mode, and so there needs to be something about what's it like to be on the receiving end of a letter, if that makes sense. So certainly at QE, it is at the moment still a GP will get the letter first with a copy to the patient, but not in all cases. So we're working through with our medical colleagues around how they write their letters, what they're writing in the letters, and there are some medics who are now writing to the patients with that copy to the GP, but it is not standardised across it. It would probably have been very difficult to have just said on this day, this is what we're going to do, because we do need to do that education and training with our colleagues. And we need to use patients to get the terminology right. So we have started a piece of work with the patient panel to look at actually how do we re-describe some of these medical interventions that have happened, and what would people want to see in that letter. So that's a piece of ongoing work, but I can't say the recommendation has been put in full, but I'm sure my colleagues from other organisations we are working to it will also speak.
Joe, Nancy?
I think Nancy wanted to go first.
Right.
So I can't imagine what it's like to be on the end of some of those letters. Norfolk and Norwich, as many of you know, is a maze, and when people arrive with letters and it doesn't make sense, so that's just on direction. So if you then add in medical terminology. So we worked with Rosemary Moore, is our chair of our patient panel. Some of you will know Rosemary. Our patient panel has been working for some time on our letters at the Norfolk and Norwich, and I hope for those of you that receive them that you've noticed the improvement. But for all of us, I think, and I can speak for the acute hospitals particularly, the electronic patient record will really ensure that patients receive their letters and information about their tests in some cases before the GP. So many of you will be able to hold your own GP records, and this is part of the electronic patient record that we're all working on collaboratively, which is really exciting. And part of that can be that you, as a patient, may even receive your radiological, for instance, if you've had an X-ray or a scan, you might receive that before you've actually received the report. And people were very worried about that, thinking, oh, well, but actually that's the right thing. So this is the future. So I think in the midterm, what we're trying to work on is as a transition, working with our local community and our expert patients and patient panel to improve the letters. So we've got a long-term solution, but there's definitely more work to do in the midterm.
Joe, how's it going at JP?
Yeah, I mean, it's a very similar place at the James Paget. We've got pockets of really different practice where they're writing directly to patients, and a lot of that tends to be in our oncology departments. They seem to have embraced it much more than many others departments. So it is about how we educate our doctors. And Nancy's right, the electronic patient record is going to unlock quite a massive change for how we provide care to patients and how patients then see that care, and we'll be able to do that in a much more digital way. So it's a really exciting opportunity for us working with patients to make sure that we've got that right as well.
Thank you. Thank you. This probably carries on. The idea of the electronic patient record probably comes into the next question as well, which is from a patient who wanted to remain anonymous. The question simply says, do you think that the primary care plan is working and that you are fulfilling the ambitions set out in the Fuller report? Looking to see who might... Tracy, you're going to volunteer for that one.
Well, I was one of the chairs of the Fuller report, and I chaired the Ageing Well and Dying Well strand, so I have a real interest in making sure that we implement the Fuller report here. There is an awful lot of work. We are focusing on primary care resilience and a lot of training as well but we're also looking at those primary care networks. And I think it would be good to bring Ian in, because actually, one of the recommendations that we put in the full report was almost stealing an idea that had already been put in place with EC, wasn't it, about wrapping teams around primary care. So it might be something that you want to talk about that's happening in your area.
Yeah.
And I know we're rolling that out across Norfolk and Waveney, aren't we, in partnership?
Yeah, so we, and this started 2 or 3 years ago, that we decided to look at how we organise it, and community services provider, we were looking where are our key relationships, and clearly there's a relationship into the acute hospital, but actually probably our principal relationship is into GPs. And so we decided how are GPs configured through primary care networks or groups of GPs, which are loosely affiliated groups of GPs, but actually it gave us something to wrap our organisations around. So we organised in multidisciplinary teams, so we broke down the silos between nurses, therapists and others working in there, so integrated teams, absolutely aligned to the primary care networks, who know the practices in there and are focused in getting to know those individuals. So that's the first bit, but it's not just community and primary care. It's then, with that as the basis, and the term being used is integrated neighbourhood teams, but it's basically all groups within a relatively close area working together, is to say, how do we then start to bring in the mental health teams? How do we start to bring in the social care teams and the various local government teams? And how do we activate that relationship into the voluntary and charitable sector, which there's a significant resource there that wants to help, but finds it very, very difficult to engage with big, relatively bureaucratic organisations. So how can we start to take that down to the lowest level, integrate at that lowest level, and really focus it around the patient, or the patient or the service user, because it's not always a patient, and making sure that when the patient comes in, we take the right service then to the patient. We don't then pass the patient between teams. So I'm not saying we've got all the answers. It's a really complex problem. But I think by starting to look at it in a far more integrated way, I think we're starting to make really interesting steps. The sort of final point is around the electronic patient records, and it's brilliant that the electronic patient record system is coming into the acutes around a system that we've now got in Great Yarmouth and Waveney that already exists, that we're linking up with the GPs in a way that we never did before. So whereas before there would be letters, phone calls, various other ways to communicate, multiple other ways, now most of that is happening electronically. Now that speeds the process up. It means that everyone can see all of the information that they need at a particular point and can take the best decisions at the best time based on that. So I think that as a framework has allowed us to move forward significantly. But it's a big problem, and it's not something we'll solve overnight.
Kath, I can see you nodding. It's obviously an area of interest for you as well.
Yeah, absolutely. So one of the things, as we were talking, we're still talking very much physical health. And I'm Kath Byford, the Deputy Chief Exec from the Mental Health Trust. And I think what we do need to do more of as a system is think about the interface with mental and physical health. We know people with serious mental illness are if people 30, I would like to say it was me, but I'm not in this category anymore, but 30 to 49 years of age with a serious mental illness are 5 times more likely to die of what is mostly a preventable illness. So actually we've got to do so much more to recognise that people aren't just physical health or mental health, but actually how do we do a better job in working together as a system, and a digital interface has got to be the solution. So NSFT, we are going to embark on a procurement, which is how we find the right system for a new electronic patient record. I think if you spoke to any of our clinicians within NSFT and you said the word Lorenzo, the antibodies would generate tenfold. So it's about how we make a system work for the clinicians, for the service users, but also have that interoperability with primary and secondary care to actually mean that we can talk together and then have better care and better outcomes for people, regardless of what their primary problem is. Because the reality is many people will have a bit of both. And we just need to recognise the whole person rather than the wound or their mental health or their leg ulcer, etc.
Thank you. Thank you. Tricia.
So in my former career, I worked in general practice for 20 years. And I've been working in CCGs, PCTs, all those acronyms for the last 10. But I actually see a huge amount of progress in ensuring that we've got the right services in primary care. So Ian was talking about the integrated teams. So exciting, absolutely exciting. The inclusion of mental health practitioners within those teams is really the way forward. But also the benefits of having colleagues working within those teams coming from the voluntary sector, or indeed in a role called social prescribing. Because in my time working in general practice, people went to the GP because they didn't know where else to go to get the information that they required. So having that social prescribing voice within the practice enables people to navigate their way through the very complicated services that are out there. And if we remember, out of every contact, 90% of all contacts with health services are in primary care. It's only 10% in mental health services or acute. So to create a system where people can actually understand where they can go to get help when they require it is a much more effective way of working. So as we strengthen primary care, we should enable people to have more contact.
I think the panel has successfully managed to answer the question which I'm just about to ask already. But I'll just ask it just to make sure if it draws out any other answers. It's another anonymous question. How are you working towards achieving a breakdown in siloed working mentality of commissioning services across health and social care in Norfolk and Waveney? What reassurance can you provide us with that you are always, where appropriate, adopting an integrated approach? How are you engaging and communicating with the public to ensure that they try and seek out the most appropriate clinician in primary care? So I think you must have just read that question and answered it already. Tricia, do you want to add anything to what you've already said? Because I think we've pretty much covered that.
So we've got a whole gamut of roles now in primary care that weren't there before. So we have emergency care practitioners, pharmacists that can undertake medication reviews, of course the wonderful nursing workforce, which will be practice nurses supporting people in wound management, but then advanced nurse practitioner roles as well, so nurses that can refer, prescribe, treat, diagnose. There will be mental health practitioners supporting in there. We have the GPs, we have the GP registrars, we have physicians associates. So all of these incredibly well-trained people that can support people in their need for services. But one of the things that we've got to do more work on is making sure that the public understand what those roles can actually do for them. And that's going back to the navigation point that I made. But very quickly, people work out that actually, if I've got a back problem, I don't need to go and see the GP who's going to examine me when I'm in pain, and is then going to refer me to see a physiotherapist within the surgery. Why can't I just go and see that physiotherapist first? So by making sure that we have the roles available, we've also got the opportunity to make sure that people get that contact more quickly and with the right practitioner. I've got a fractured shoulder at the moment. I'm looking at Louise, I was just sharing that. And the person I need to see is the physio. They're going to be the person that makes the huge difference to me. So in that setup, we're in a position where we can make sure that people go to the right person within the workforce.
Thank you. Tracy, you were going to add something and then...
Yeah, I think it's a great question because it's why we're all here as an integrated care board and an integrated care system to pull everything together and have that consistency across Norfolk and Waveney. And before we had the integrated care board, we had 5 different clinical commissioning groups across the piece. So they would look at the prioritisation completely differently. But what it's meant is we've inherited a situation where, for example, if you're looking at stroke services, they may be provided very differently on one side of the patch to the other. So we're doing a community services review at the moment to make sure that there's this baseline of care. I mean, of course, you know, in different places, working with different voluntary sector partners, we might have different services if people are asking for them, but that basic core of service we want to make sure is available in the same way to everybody. And then one of my acute colleagues might just want to talk about the work that the 3 hospitals have been doing as well, because there's been a lot of close working between the 3 to try and align different things. Some of it is about having that electronic patient record, because that's all 3 hospitals doing the project at the same time, which is quite unusual. But there has been a lot of work just on sharing best practice, hasn't there, and aligning care as well.
There certainly has. So the electronic patient record, I'm delighted to say, is going to sit across all 3 organisations, will come in the next couple of years, and is going to be a mammoth project. But before that, we've really got to look at how our acute clinical services are designed, where we're delivering them, what we're delivering. And Jo is, so I'm going to put Jo on the spot. Jo is a senior responsible officer for that across the 3 organisations. But I guess I would also say that whilst it sits as an acute clinical strategy, the connection with our mental health colleagues, with our community colleagues, is absolutely integral in that. But I'll let Jo maybe speak a little bit more about it.
Thanks, Alice. And you're right. We've developed an acute clinical strategy that really looks about how we provide clinical services in the acute hospitals across the 3 acute hospitals, so across the whole of Norfolk and Waveney. And there are differences. There's slight differences in clinical practice. And some of that will be absolutely needed and some is unnecessary. So as part of the recovery from the pandemic, we're really looking at how we can standardise practice across the 3 acute hospitals, but also in preparation for this electronic patient record. So it doesn't matter where a patient accesses our services, they would receive the same clinical pathway through their clinical condition. And I think the next step is how we really join that up with the community services review and how we really link in with primary care colleagues and community colleagues and mental health to make sure that we're all working on those clinical pathways together. I think one of the projects that Alice and I are certainly very excited about is the new hospital builds that have been announced this year for both the QE and the James Paget. But there is an absolute recognition that it's not about building the same hospitals again. We've really got to think about how we transform those services and provide them in a way that's fit for the future, because this is our hospitals that we are building for the future generations for Norfolk and Waveney. So we really have, I feel, a huge responsibility for that, to make sure that we get that right for the future. And we will absolutely need to engage fully with all of our public and community services and patients through that journey.
Yes.
Thank you. Part of the question related to how we commission better to get better integrated services. So I just thought it would be helpful to share with the audience a few examples within mental health and the relationship between the Integrated Care Board and the Trust in terms of taking services to the individuals rather than the old-fashioned approach of going to a GP and then having to be referred in many cases. So we have a very successful programme of mental health practitioners that work, are NSFT staff, but are based in GP practices. So again, taking that concept of if somebody needs support, you don't always have to go through a GP in order to get access to those services. The other example I thought would be helpful to share relates to the mental health support workers in schools for children. So actually, children are in schools most of their time, actually, if we think about it, and where they may exhibit some problems, challenges, worries, etc., then surely the best place for those young people is to access early intervention and support whilst in their school environment where they feel safe. And again, this is coming through the commissioning of services and how we can look to make better decisions collectively as system partners to place mental health services where our service users need them the most, as opposed to them having to navigate through that old-fashioned route. Now, I'm not saying for a second we've got this nailed or cracked. There's still loads of work to do. But actually, those early examples, we've got the Community Transformation Programme within mental health. We've got lots of other services where people can access mental health support without having to enter the Mental Health Trust. That's actually the direction we should be going, not a reliance upon big trusts like the mental health trust, like the acute trust, actually where people need care is before anyone ever needs to get to those secondary care or acute hospitals or mental health trusts, etc. And much of that could prevent the deterioration where somebody then potentially has life-changing consequences. So I think that's where we have a really exciting opportunity to continue doing what we're doing, moving services away from where they have done for the last 20 odd years plus, but where do they need to be for the now and the future?
Thank you. I've just observed, for example, we've got Norfolk and Waveney Mind outside with their drop-in centres, which are the sort of services that you're talking about,
Yes,
I guess.
Absolutely.
And sorry, Alice, go ahead.
No, I was just going to say, I guess the one learning for me from all of this is we've got to make it simple. People have got to be able to drop in. Nobody is unwell 9 till 5, Monday to Friday. And so whatever we do, we've got to make it at times when people are likely to need it and as simple as it can be. And if we do that and as close to home or with technology, my children always laugh at me as with technology, but you know, we do have technology. How can we use that to really support people? Not everybody wants to use it. Some people still want that traditional face-to-face contact, but you want it usually outside of the hours that it's often offered. So I think that's something that certainly I've heard as we've gone around with the new hospital programme. How do we do that, and how do we do that together? Because that is going to make it more robust and more sustainable.
I think I'd just observe as a very interested, if you like, observer of our health and social care providers, we do have a fantastic team of leaders, many of whom are represented here today, and the appetite for integration and working together and cooperation and looking at new ways of doing things is really refreshing. And it's already producing benefits that are being felt by patients across the patch. So please keep doing what you're doing. I think it's very, very positive. Question now, which isn't quite so positive and is very specific. Can someone tell me why there seems to be a lack of renal consultants? I'm supposed to see someone every 2 months as my EGFR is 9, but my last appointment in July was 6 months, only after I'd rung and complained. It's now nearly 3 months again and no sign of an appointment. We have the wonderful dialysis unit at Bowthorpe, but other than that, no care for pre-dialysis patients. The consultants I've seen over the last 30 years have been wonderful, but getting to see them now is impossible. I had better care 30 years ago.
And that was from Lynn, wasn't it? So
It was from Lynn, yes.
Yeah, so thank you very much for raising that. And I am really sorry that you've had to wait so long, and for any patient in any speciality. And this is something that across all of the services we are trying to get across, that we are working as hard as we can to make sure that patients, one, don't deteriorate, but if they are, we're picking them up early. What I can say is that at the Norfolk and Norwich, and we do have renal units across Norfolk, we have 9 renal consultants, and 2 of them are part-time. And for most part, so there will always be a backlog at the moment, but I would say right now it's probably 75% of those patients are being seen within their booking time. So what the consultants are trying to do for that last 25%, and I'm sorry if any of you or your relatives are in that 25%, they're trying to make sure that the patients are assessed by their teams to pull forward as a clinical priority. It's really interesting, particularly renal medicine, because it's a growing aspect of our ageing population, so cardiac, renal, neuro, so stroke, we talked about stroke earlier, with all of our dementia services, as well as hips and knees, so the orthopaedic type things. The rise is exponential for Norfolk. So it is how we manage across the acute hospitals together. So that's something we work on together, how we manage the prioritisation and optimise across the 3 of us. And many of the specialities across us, we are trying to find solutions so that patients don't wait. So that's one of the things that we're working on. That's not just for surgical procedures, that's for other specialities too. But I know that the renal team, the kidney physicians, are looking at the very large number with one particular consultant and how they can make sure that those that are deteriorating are seen. So, and certainly, if there is anyone that's worried, please contact me personally. We will look at that. What I would say is that for many of you, and Bowthorpe was mentioned, and when we work through Bowthorpe and the kidney centre, we thought that it would take some years before it was maximised, but already our numbers for kidney patients are incredibly high, and that is utilised extremely well. And if anyone hasn't seen it, it's like something out of NASA, because it is so beautiful. But of course we have North Norfolk as well, so we have Cromer, and we have an inpatient unit for dialysis as well for those patients who are sicker. But we also have dialysis at the James Paget. So between us, we are trying to work through these groups, but those particular groups of patients are rising. So it's how we plan together, and I mean together with all of the integrated services, and how do we manage our cardiac, so our heart and kidney numbers over the next 5 to 10 years. But we are certainly working very hard across all of the organisations to make sure that we reduce this backlog.
Thank you very much, Nancy. Kathy, you wanted to add something?
Yeah, thank you. It certainly doesn't deal with the here and now, but I think if Stuart was here, who's our Director of Public Health for Norfolk, I guess one of the things he would be saying is, if we use kidney disease as an example, that is one of the consequences of diabetes, which is a consequence of poor lifestyle, potentially some genetic as well, obviously. And actually, we need to think about not just how we're dealing with in the next few years, but how do we stop this becoming a complete unmanageable problem for our whole population and therefore our health services? We've got to think about that together as a system, and I'm saying this as another nurse, sorry, but rather than the representative of the Mental Health Trust, but some of our patients are on medications that cause a much higher risk of obesity and diabetes. So again, I'm looking ahead another generation maybe, where we're going to be seeing more and more and more demands on a service that is already struggling and will continue to struggle. We've got to think about the workforce, let alone the physical capacity. I'm not even going to mention the money, but actually we do need to think a bit bigger than just trying to fix the immediate problem, but we need to think about 10 years, 15 years, 20 years, and what we can all do. And when I say all, I mean the population of Norfolk and Waveney in this instance, and of course Suffolk for the rest of my patch, how we all collectively take personal responsibility for trying to reduce the burden on the NHS, but also live better, healthier lives for longer.
I guess the only last bit for me is when Nancy spoke, absolutely talked about a percentage of patients who aren't receiving necessarily their care in a timely way. There was an omission around QE, a deliberate one, because the Queen Elizabeth and West Norfolk received their care through Addenbrooke's. So we go through Cambridge on that particular thing. We have a renal dialysis unit, but I would say if anyone is also feeling that there is significant concern around the West Norfolk area, please come back to me and we'll absolutely pick that up. So I just wanted that clear.
Thank you. Thank you. Jo?
Not specifically about renal services, but Nancy was sort of listing some of those longer term conditions that we're now having to manage, and there's greater demand for it. And I think there's national recognition that the way that we provide outpatient care as an acute hospital is very outdated. It hasn't really changed since the 1940s. And there is a national piece of work looking at that outpatient strategy and how we manage patients in an outpatient setting. And I think our patients will see a significant change over the next few years. We're already starting to look at how we manage our follow-up patients and long-term conditions. And previously there was routine practice to have yearly follow-ups. Every patient would just, well, we'll see you in another year to see how you are. And we have to manage that in a very different way. So we've been implementing what we call patient-initiated follow-up. So people that still have open access to services, but they contact through to the hospitals when they need it, rather than on those yearly appointments, just to really try and maximise how we provide appointments for new patients as well as follow-up patients that absolutely need them. So there will be redesign of outpatient services over the next few years, and how we use digital technology to support that. We know that there's monitoring systems in place already that we can use and we're already deploying. So that makes it much easier to be able to monitor patients in their own homes, but still under the care of secondary care consultants.
Thank you. Thanks very much. I've got one more. Well, I've actually got two more questions submitted, and I will then open the floor to if there are any other questions from the floor. This is two questions that are really both about GP practices. So the first is from Douglas Lewins. I registered with my GP practice in June 2021 when I moved to Norwich. As a place where it is the needs of the patient that should matter, more information is withheld, contact possibilities have decreased, and GPs have become invisible. We have no patient participation group. The ability to see documentation and correspondence in my medical record has been removed. The ability to use email to contact the surgery has been removed, and face-to-face appointments with GPs have become more difficult to obtain. The second question pretty much says the same thing. I needed to book a face-to-face appointment for a health condition. I was concerned about the time it was going to take for the appointment. I was told the practice opening hours have changed, not opened so late in the evening or weekends, talking about when people need care. This coupled with the fact I can no longer order repeat prescriptions over the telephone, etc. Can you let me know what is being done to ensure face-to-face contact continues, and also clarify for me what the process is around consultation with the public when a GP practice's hours are reduced? So that's a sort of litany of problems with probably one or two GP practices, but I guess that may not be specific to those two. So I throw that open to the table. Tracy.
So I'll just start, and I would say there can be quite a bit of variability in GP practices, but in general across Norfolk and Waveney, we are much higher for having face-to-face appointments, which is quite possibly because we have an older demographic as well, and people feel more comfortable being seen face-to-face rather than online. But it's over 77% rather than 68% nationally, so that is quite a big shift. Also, we're providing more than 600,000 GP appointments every month, which is more than half of our population going to the GP every month. So practices are working really hard, but as I say, there's variability. One of the reasons that some GP practices have pulled away from doing repeat prescriptions on the phone is a worry that they might not hear properly what's being asked, so there might be mistakes. So it could be that they've moved to email and letter and other ways of doing that. And we do have a standard contracted time between 8:30 and 6:30, but we do have extended hours for GPs as well. One of the things that I would recommend is if people are having specific problems with their GP practice, to either write to their GP practice. If they do so, they can also write to us as well if they don't get anywhere. And also, if you're within the catchment area, you can consider moving GP practices if you're not happy with the services being provided, or there is another GP practice close by where you think, actually, that might work a little bit better for me. So they're just the things that I'd like to come in with, but colleagues might have other ideas as well.
Anybody like to add to those comments?
So I think Tracy's point is well made about variability. And I think this is what the team within the ICB is working very closely with practices to try to minimise that variability. As Tracy has mentioned, we do have a really high number of face-to-face consultations happening in Norfolk and Waveney in comparison to other areas in the country. But if you're somebody that's finding it very difficult to get to see the person that you want to see, then you're not interested about what the statistics are. You want to see that person. What I would say is that we have people that don't want to use technology, such as repeat prescriptions being ordered online, using apps, using communication channels of that way. And I would be very, very sad if we got to a position where people couldn't still have that personal contact. So we're very conscious within those conversations that we're still encouraging a variety of ways to access the service so that you don't only have the one option. So I think from the perspective of primary care, there is still much to do. We've talked today about the additional roles that are available to help and support people. But it's one of those areas that there is such high levels of demand at the moment. We're having to constantly think about how we address that and make sure that people can have those contacts. But as Tracy also said, if there are individual problems, then I'd always be very interested to hear about it.
And
in
I'd
the
also
ICB.
say that Healthwatch Norfolk is very good at listening to the voice of the patient. So if you do have concerns about any particular surgery, please get in touch with Healthwatch Norfolk. But Joe, you wanted to add something.
Yeah, just thinking about some of the responses we've had today. What we haven't really mentioned today is the workforce in the NHS, and we absolutely know that there's some pockets, certainly in primary care, where we've got a real gap in our workforce. I think we all really welcomed the National Workforce Plan that's been signed off by government and the NHS, but I think it's a few years before we're going to see that come to fruition. You know, GPs take quite a long time to train, and you know, we need to see how that will progress through the next few years. But also thinking about that real alternative workforce and how a lot of the primary care practices have really embraced using different workforces. And there is, I think, an onus on us about how we educate people with the different methods of being able to get help and support that we've already talked about today. But I do think we have to recognise that there are some gaps in our workforce across Norfolk and Waveney, as there are across the whole country.
Thank you. Thank you. Ian.
And I think it's a really difficult problem for a start. And I think there are issues of workforce, and access to GPs is always going to be really, really important for those that get the best service by physically going to see a GP. But we've got lots of other methods now and a number of people who prefer to use other methods. Now, I don't know, I'm not a GP, I'm not involved in primary care, but I know within the community care that as a result of COVID, that we've looked at some of the ways that we contact patients and have the initial interaction with patients. And one of the things that we found is things that pre-COVID, we would never have done. So if you'd asked around certain specialities, could you have an initial consultation by phone with someone? They'd have said, no, that's impossible, you can't do that. But by the fact we have done that, and during COVID, we were forced to go further than we'd want to. But the answer isn't to come back to zero, because the great thing is that you're able to engage with someone, identify if there is a problem. That means that those that really do need that contact are prioritised much more quickly and do still get that contact. Those that can have another method, which has to be suitable for them and has to be clinically appropriate, can access that more quickly by other efforts. So I think we need to be careful we don't have a binary discussion about more contacts, less contacts. We've got many more things we can do, and I think it's important we use all of those, which means for those people that do need that face-to-face contact, they can get it quicker, because the number of people who are happy using other ways to contact or can get the best service more quickly through that other way do access those services in that way. And I think it's really important we keep that in the balance of the discussion.
Thank you. Well, I'm sure you'll agree that's been a very helpful session, but I'd now like to open the floor in case there are any questions from the floor. Yes, madam. And what I'm going to do, because we haven't got a roving mic, but we are being broadcast, if you tell me the question, I will repeat it so that it's on the record.
This comes under learning disability and social care. We're here to correct an inaccuracy that, when read, gives an inaccurate impression, possibly leading to an unfair assessment for a vulnerable individual with a learning disability. We have gone down the route of speaking to the people that made the report, also emailing, and we haven't got any good outcome. We want to get this resolved, and we're here today to get your help without delay and by means of standard intervention discussion. We'd rather have to go down this route than have to make a formal complaint and to get this sorted out. We'd like to explore the possibility of resolving this, and I'd like to speak to you at the end after the panel finishes in more detail.
So the question is around response to your inquiry regarding a learning disability?
and it wasn't accurate. And it actually is legal that a report should be correct, and it also involves other professionals and what they've written, and also the individual's true account, and they've listened to what we've said, and they got the information from their colleagues by talking, because I asked where they've got the information from. The information needs to be accurate because it will, as it stands, it will give the wrong impression, and the person that we're talking about will get the wrong help. And we've also been told that we've passed a deadline, and we consider that if something's inaccurate, there should not be a deadline. It should be sorted. All it means is we've sent an email with what needs to be corrected. And all it needs is a few sentences removed and a legal part added in.
Okay, thank you very much. I think that sounds like a very specific question for an individual, and I just wonder whether Tricia and maybe Kath can deal with it either directly now or afterwards.
So I wasn't clear from the question whether this is an issue with social care.
Yes,
or
it's
social care, but I'm more than happy to meet with you after and have that conversation with you today, and then to liaise with my colleagues, because it doesn't sound like it's great, so we'll see what we can do together.
Yeah.
Okay.
And Madam, just to be clear, Tricia is the Chief Nurse for the Integrated Care Board. And you may not know, but she is the Chief Nurse for the Integrated Care Board. Any other questions? Yes, Madam.
Forgive me, because well, it's not a question. I'd like, first of all, to make a comment about what I've heard. First of all, I'm totally in agreement with integration, and I can see that you're talking about systems and these overarching bodies that make the decisions. My concern is about the person at the bottom. How do you ensure that that person, that one individual, is going to receive the integrated help they need? Because what I see is a complete lack of integration. I see buck passing. I see people, not just in my own experience of being a carer for someone with senior mental, not senior, I'm being senior at the moment, serious mental illness, but I listen to other carers with myriad problems, people with physical health problems, mental health problems, and they don't know where to go. They honestly don't. We're constantly, a group of us on like a Zoom call, try to help each other. We use our own experience to say, oh, well, try this, try that. But the reality is there are too many places for people to have to go, and there is no clear person responsible, ultimately, for the people that we're looking after.
So just for the record, the question is, how is integrated care, how are multiple services delivered, or how is the patient aware of what multiple services there are when they have complex needs?
Well, when they have complex needs, the person being aware of them is just irrelevant, because they can't deal with myriad, organisations. You can't say to a person who is struggling with mental problems, I'm talking about my own situation, but I'm talking about other people as well, people who might have learning difficulties. How do they just go to so-and-so and say, oh, well, I'd like, a physiotherapist, because a physiotherapist, may or may not exist in that practice. It's too fragmented at the moment, and I congratulate you on your willingness, I suppose, to try to improve matters, but my concern is about the person who, at the bottom, who is forgotten,
Yeah.
who's not able to access all of those services, who doesn't have an advocate, who, you know, whose mental health is not being supported, or who has physical health problems and they're not being supported, who can't go through the system of trying to get a GP appointment because, you know, they're not going to sit on it at the end of the phone for half an hour and be told, oh, well, we don't have any appointments anyway, so try again.
Thank you. Yeah. Ian, I'm going to look at you to see if you might like to start off with that. How does somebody find the right door into all of the care services and healthcare services that there are?
I mean, I think the first thing is to acknowledge what you're saying is absolutely the case, and we need to get a lot better at this. And I think it shouldn't be incumbent on an individual I'm relatively new to this area and to this role, but it's confusing for me, and it shouldn't be hard for people to access, and we shouldn't be placing the onus on individuals to have to navigate what is a complex system. I think there are certain things we can do, certain things we've tried to do. So within integrating our teams, it means that it doesn't matter whether the first person that comes to see you is a physiotherapist, a nurse, an occupational therapist, or someone else. They do the assessment that then works out who is the next most appropriate person. So they don't say, oh, I've done my bit, I'm now going to get in touch with the physio who will come and do their bit. So I think the first bit is that we get much better as organisations at taking all of the information, not just the bit that's very specific to the individual skill set, and then doing that navigation throughout it. So we're starting, and across, I can talk for the sort of Great Yarmouth and Waveney area, but it's across the other areas where we're very conscious and trying to work at different ways of doing it. There are individual examples where I think we've got great roles at relatively new and a relatively junior level, so the health connector roles, which have come in, and we haven't got enough of them, and we're not joining them up, so it's relatively early days. But the role of these individuals is precisely that. So they go in, they're community-based, so they're going to individuals in their own home where there is a complexity and where there are often multiple complex requirements that it's unreasonable to expect an individual a carer or the patient themselves to understand. And their role is exactly that, is to try and connect up the services. So they're working closely with GPs, they're working closely between the community and the acute providers. And really importantly, the bit that we need to get much, much better at is working at between health and care. And we are trying, as an organisation, we are trying to do that, and we're starting on this journey by the greater integration. But I think that the first thing to acknowledge is there is a huge distance to go. It's an incredibly complex environment for people who are in it. So we need to get much, much better for people who don't understand that complexity, so they don't have to build up either an individual experience or, as you say, a sort of collective experience by a group of people. So I think it's to acknowledge that you know, the problem is understood. It's not an easy problem to solve, and we need to get much, much better at doing it.
Kath, I'll come to you in a minute, but Tracy, this is part of the commitment of the integrated care system about the patient only having to tell their story once.
Yes.
Which clearly means telling the story to the right person, who's then got the range of services available, and also having the electronic, the shared care record.
I was going to mention
so
that,
that once you've told your story, that story can then be shared with other people. Is that something you want to add a little bit about?
Yeah, so I was thinking along the lines of the digital work as well. So the shared care record is really important because it means that we can share information between health and social care, and also between some of our charitable partners as well, which is already making a big difference. As Ian said, we're putting some of these things in place, like the health navigators. We haven't done enough of it yet. It's still early days, but this is where we want to move to, because as I mentioned about the case that I talked about in palliative care with a dying relative, when you've got 16 different people turning up at your front door, and the person that has to organise all of that is you, and you're busy looking after a relative, then that's really unfair. So we're trying to find ways that we can take that away from the patient and make seamless around the patient. But we've also got to learn while we're doing that as well. I think we've got to work with Healthwatch, we've got to work with all of you and see what works and what's just going to add unnecessary bureaucracy, because that's the last thing that we want to do. So it's going to take us a bit of time.
Thank you. Kath.
Thank you. Thanks for your question. I think in terms of, if I'm putting my mental health hat on now, because your example relates to severe mental illness, one of the first things I wanted to say is the input of the experience of not just service users but carers, family carers, is absolutely critical. There is so much for us to learn from. There are people like us in positions of authority and influence but don't necessarily have that lived experience, which we are foolish when we do not seek, listen to and act on. One of the pieces of work that we've started over the summer in relation to this particular issue of the lived experience of carers is a partnership between NSFT and Healthwatch Norfolk. And we had an event a few months ago where it was all around the experiences of the carers who have for years and years and years struggled with the experience of trying to navigate around systems that just don't work for people who are not able to manage them themselves. But also the voice of the carer not being listened to by us as a health and care system. And for me, one of the biggest ways forward is a mindset change of all of us, of listening and valuing those the voices and the lived experience of people who know what they're talking about. And we are absolutely losing the opportunity to know the direction we need to go in when it comes to changing the way forward. So to make sure we don't just put something new in place, but actually that doesn't crack the problem. In this event that we put on, it was very emotional hearing the experience of people with lived experience, and there was a lot of colleagues around the room, not just within the health and care sector but the voluntary sector. And for me, that's a big way forward in how we work to support our population that may need support, but not always from those traditional health and social care organisations, but people who are very skilled and very experienced in the voluntary sector who can help people navigate through the complexities of health and social care. And I think the final thing I just wanted to say relates to the consequences of us not getting this right. So I made reference earlier to the consequences in early preventable death amongst people with severe mental illness. And a big part of that is because they're not able to access or navigate the services to access cancer screening, for example, manage their housing and maintain a tenancy, for example. They may be much more victim to crime or abuse. All of those things, we have vulnerable people in our population that need that help and they're not getting it consistently. That needs to be our, not just ambition, but commitment, targeting the health inequalities for our population and then putting in mechanisms which won't, I think there will always be challenges, but people are ending up using the wrong services at the wrong time because we're failing them at that earlier stage. But I will shut up, sorry, but I think it's about listening to the voices of the people who know what they're talking about, and that isn't us, that's people, and that actually is maybe the way we can make a real difference going forward. But thank you for your question.
Thank you, Kath. Tricia.
Sorry, do you mind if I was just going to add, so thank you ever so much, Kath, the word carer, because I did not once hear the word carer before your comments. I did not hear the word carer, and yet we're told that carers save the country billions of pounds, unpaid carers, and they struggle. I know they struggle because I talk to them, and I'm not just representing mental health setting, whatever setting.
Absolutely.
I think it's really important not to forget the voice of carers.
Absolutely.
Thank you to carers' voice for listening. and to NSFT and to Healthwatch.
I'm going to take 2 more questions from the floor, but Kath, sorry, Patricia, you wanted to respond.
So just picking up on the care, I'm sorry, I can't quite see you. On the carers point, I mean, it's such an important point of discussion. So we rely on the support of carers to their loved ones for us to be able to deliver care most effectively. So if we're not saying it enough, we need to say it more. There's a huge amount of work that is happening which may not be visible within the ICB. Carolyn Fowler, who is the chief nurse at NCHC, is leading a team working with Carers Voice. There's been the development of the Carers Passport, which has been really helpful, but we need to do more of that. But I just wanted to go back, when you raised your question, you talked about LD, learning disabilities. And I now have a team working with me in the ICB of learning disability navigators. So when we know that families are experiencing crisis with their child who has a learning disability and or autism, we're able to align that navigator to the family to support the carers and support the young person. And it has been really well evaluated by families, but it's making a huge difference to those children as well. So I've got an absolute desire to do more of that, allowing for the finances that we've all been talking about. That role has been, it's been game-changing. So we really need to think about how more we can do of that role. But thank you for your question.
Thank you. Now, I'm only going to take 2 more questions. Gentlemen here.
This is about the legal obligation of a local GP to provide access to healthcare for a person with learning disabilities. Do they actually have a legal obligation?
So the question is, do GPs have a legal obligation to provide healthcare to people with learning difficulties?
So for the duty of care, irrespective of whether you've got learning disability or diabetes or heart failure, if you are registered with a GP, there is a duty of care.
Okay.
It's as simple as that.
But
Yes.
going on from that, can I just ask, if we have a problem with persuading our local GP to provide that service, what is our route through this? Because do we need to go to another professional body further up the chain to actually influence this?
Are we meeting at the end?
Yes,
we are. Fine. But essentially there is a process, an escalation complaints process, which I can talk you through. But it's absolutely right and proper if you don't feel your voice is being heard, that you know how to ensure that you have the right conversation with the right person.
Okay.
So you'll continue that afterwards.
Yeah.
Thank you very much. Yes. At the back. Yeah.
I think will affect everybody, or lots of other people. It's the position of when somebody finds it difficult to go to a doctor's surgery, are they not entitled, they're registered with that practice, to have people come out and help them in the home to give the same care? Because this is the trouble on their mind.
So when we have that chat, we can explore that, because there's legal grey areas, so I need to understand it in more depth.
Yeah.
More than happy to do
Okay.
that.
Thanks very much indeed. So you'll continue that afterwards. Yes, at the back.
I want to say thank you for mentioning the Carers Passport, because that is a very, very important thing that's coming out through Carers Matter and Carers Voice. There is one obviously at Norwich, Norfolk. Personally, I did not get offered that service. I'm down, I know I'm in a wheelchair, but I am a carer for people with Asperger's or ASD. It wasn't offered, and now the 2 passports are out. Is there going to be a linking of the system under the whole thing of being linked together? And what provisions are there for making general public carers aware of this passport? Because it's so important. I was left for 8 hours, sat in the reception whilst my husband was having surgery, and he was in a general ward, and he doesn't do strangers. He has major issues with crowds and things. I know a ward's not a crowd, but similar thing. So why isn't it a point of even the pre-op when a carer goes in with a patient, is it not offered at that point?
So this is about accessibility to the carer's passport. Yeah.
Thank you. Because our carer's passport has been around for quite a while, but I take your point, and in fact you've hit upon the theme we've all been talking about, which is disconnected. So Sarah Higson, who's the lead for patient experience and patient engagement at the Norfolk and Norwich and the Carers Forum, and we work very closely. She is leading a piece of work. So across Norfolk and Waveney, it is one, because we can't have differences. And you're right, it doesn't matter what route you enter the hospital at as a carer, that you should be offered it. And I can confirm that that is now a very key question on the new documentation at the Norfolk and Norwich, which will shortly be introduced. But of course, what we need to do is that it doesn't matter which route you access, because you've heard us all talk about how we're sharing, trying one list of patients, if you like, to try and make sure we see patients and their carers quickly, that it's the same. And that's the piece of work that's ongoing at the moment. And then we can breathe a sigh of relief because it will be Norfolk-wide. But you're involved in those conversations, aren't you? So thank you very much for your participation.
My second part of that was how you as an organisation and you as a group aiming to advertise basically the service of the carer's passport when it is pretty much going under the radar at the moment unless you know to ask for it.
So I'm just reflecting back on the first board we had when we became an integrated care board, and I think I'd been in post about 2 days at that point. And we had the most amazing presentation around the role of the carer, the importance of the carer, and what were we going to do about it as an ICB. So I'm really quite heartened that although it's not everywhere, there has been a lot of progress in the last year. We need to take it further, and we need to take it further at pace with really strong communication, which will happen. But of course, there's still more to be done.
Yeah, I mean, I found it very helpful being a carer and a user, being part of the process through Carer's Voice. It generates in the actual Carer's Voice passport or Carers Matter Carer's passport. Did they have a similar process with the Norfolk and Norwich in bringing that forward to say what do you need? Because the other thing that came up, and I think this is relevant to all ages, because obviously people want to access these systems, but not everybody is computer literate. I'm a digital inclusion volunteer, so I know I get frequent phone calls off of friends going, how do I do this? So, but is there sort of like more than one version gonna be put out there? So like a physical card, a digital card, that sort of thing. So people that know how to use it can just have the digital card, it's on them all the time. Or is there going to be a physical card or a sort of register?
So I don't have that level of detail, but if you don't mind, if I could grab your personal details afterwards, and I'll get Carolyn to give you a call, who'll be able to tell you a lot more than me trying to fudge the answer.
That's super.
Wonderful presentation. Yes.
Well, thank you very much indeed. Thank you for all your questions. I'm sorry we couldn't just make it completely open-ended, because I'm sure there are more questions, but hopefully you might have the opportunity to grab some of the people at the top before they go back to their day jobs. Well, this is your day job as well, being answerable to us. So can I say a huge thank you to all of you for your frankness, for making the time available to answer some quite challenging questions and to be frank and open about it. I know it's a jolly difficult job, and I'm sure you all wish you had magic wands where you could make it better, make the money better, make the response times better, and so on. But I'm sure that we all agree that we're heartened that there is so much positive conversation going on amongst our health and social care leaders to make things better for us and our loved ones. So can I ask you just to show your appreciation for our panel today? Thank you very much indeed. And can I also just pass on my personal thanks to the Healthwatch Norfolk team, to the staff, the trustees, and of course our volunteers for all their support and hard work over the last 12 months. And to tell you a little bit more about what Healthwatch Norfolk has been up to in the last 12 months and some of the projects they've been working on, I'm going to hand over to our Chief Executive, Alex Stewart, who himself is celebrating a decade as Chief Executive of Healthwatch Norfolk. So, Alex, congratulations. Here's to the next decade. Keep going. Keep surviving. Thank you very much.
Thank you. I've obviously been very naughty in a previous life. But anyway, thank you for your comments. And again, thank you to the panel. This event is particularly important to us this year as it formally marks the first decade of Healthwatch Norfolk. When I first joined the team with the then operations manager and now trustee Chris MacDonald, who's lurking at the back, we had a passion to ensure the experiences and feedback of the people of Norfolk should help them to shape the care our fellow residents receive. As we complete what is probably our busiest year ever, I don't think we could have believed just how many experiences, feedback, project work, recommendations and changed outcomes we would achieve. Is there still a lot of work to do across the health and social care system? Undoubtedly. Some of these improvements and changes can be down to national policies and budgets, which we aim to influence but may not always be able to challenge or change fast. What we have done, though, is worked hard to ensure decision makers know what the public are saying and how things should change. My opening remarks again this year really do echo those of previous years. It's been an incredible 12 months. Our annual report gives us the full picture of the range and scale of the work we have undertaken. And you can also enjoy video highlights shortly when I will shut up, which recap the efforts of our team of staff and volunteers over the past 12 months. You will see this in the video, but I make no apologies for firstly preempting the figures you will be about to see about the work we've done. Some of the successes in our first decade: ensuring thyroid patients, thanks to two ladies sitting here, get the best medication to treat their condition. And you will hear more about that from two people who have worked hard alongside us for that to happen in Norfolk and are continuing to campaign and battle nationally. We worked with 6,500 young people across Norfolk to ensure they understood what health and social care actually meant. Some of the answers we got were hilarious. The GP should come and see us in youth clubs, and they should sit and drink kale juice, fruit juices and things like that. But they did all participate. We supported people with advice and information across the COVID-19 pandemic and had incredible help from Louise Smith from Public Health. We ensured decision makers locally, regionally and nationally, including the Health and Care Select Committee, were aware of the lack of NHS non-emergency dental care in Norfolk. We ensured consultation over a review of Norwich's walk-in centre was accessible to everyone, and in the last year alone, our workload has increased dramatically. A total of 2,656 people shared their experiences of health and social care services, with us helping to raise awareness of issues and improve care. Meanwhile, 471 people came to us for advice and information about a wide range of health and social care topics. We published 56 reports of various aspects of health and social care, which is a huge increase from the 16 in the previous year. The loosening of COVID-19 restrictions meant we could get in and get out into the community far more frequently. And those reports varied in scope, including our ongoing work around community mental health, our My Views Matter reports visiting residential settings for those with learning disabilities and or autism, engagement reports including our work finding out the views of GP patients, and a number of reports based on what we heard from people when we visited GP practices, pharmacies, libraries and community events around the country. I can't take any credit for this. My team really are absolutely bloody amazing. When it comes to sort of key trends, dentistry remains the topic of the month. We hear more about that than anything else, with people still struggling to get non-emergency care, excuse me, if they're not already registered with the practice. We submitted a dossier of evidence to the Health and Social Care Select Committee outlining the issues being faced by people in the county, along with several suggestions to help alleviate the situation, ranging from another look at dental contracts to ensuring there is more oral health or education for young people, like the fantastic work that's actually being done by plumbers with their Happy Smiles events with children. The future of the Norwich Walk-in Centre was also a big issue, as many of you will be aware, and we added our voice to concerns about the way the engagement around proposals for the future were conducted to ensure that they were as accessible to as many of the population as possible. And to the credit of the ICB, they listened to what we were saying and eventually, we feel, came to the right decision, which was to keep the service, and that forms a part of our video review shortly. Although the full impact of it will be part of our annual report next year, our My Views Matter work really does need to be mentioned and stressed. No one can fail to be moved by the deaths of 3 patients at Causton Park Hospital, and off the back of concerns that patients and their loved ones were not being listened to. We decided to visit a number of residential settings to those with learning difficulties and/or autism. It was heartening, and we understood and were told about the kind of problems Causton Park was experiencing were not widespread. But we have identified some areas of work, including the need for more care staff, which is also of national concern, the importance of residents having a major say in their living areas, the chance to pursue interests as independently as possible, and the chance to forge as wide a social circle as possible. We're also very mindful that the needs of carers, of those with serious mental illness, are borne in mind when it comes to services for patients in Norfolk. We have worked with NSFT and 3 wonderful carers to facilitate a conference which dealt about carer stories, and we're currently completing an action plan for improvements which we will come back to and we'll be able to tell you more about in the weeks and months ahead. The carers we work with share our thirst for progress on this issue. Internally, we're also scrutinising the work we do. In the bubble of working together to gather patient feedback and the day-to-day demands of our jobs, it can be hard to think about growth and development. Because of this, we are working on a quality framework which sets out and sees all our managers, staff, volunteers and trustees take a role, if they wish to look at different aspects of our work, both internally and externally, and to take stock of what we're doing, learn from what we're doing well, and learn how we can improve. We're pleased that when it comes to our commissioned work, we're working on longer-term relationships now with many health and social care trusts and bodies, so that we can work in more detail on more projects for more time to ensure better care and support for the people of Norfolk. Before we look ahead, there's now a chance for you to recap some of our efforts as we condense 12 months' work into around 7 minutes with this video of the year.
Bringing health and social care together. The new system overseeing both aims to do this and ensure there's a closer working relationship, which should mean better care and support for all of us. Healthwatch Norfolk's statutory role is to ensure the voice of the patient is at the core of this, taking your views, ensuring they're passed to those who make the decisions and, when necessary, holding bosses to account. We've done that this year. Dentistry and the difficulty of getting NHS non-emergency care made up just over half of all our inquiries. We ensured the breadth of concern was reported to health leaders on a local, regional and national level, including sharing it with the government's Health Select Committee. This remains a priority for us and we'll be ensuring progress is made on dealing with this huge gap in care, now that responsibility for dentistry rests at a local level. The future of the Norwich Walk-in Centre was also a major worry for many. While we accept that services need to be renewed and revised regularly, we highlighted flaws in the way the consultation was carried out, a view supported by the local community and many of those working within healthcare. Indeed, the walk-in centre was something we did some work on ourselves during the year, talking to patients and understanding what worked well and what could be improved. Around 250 people a day use it, and we discovered a need for more clinics, better communication about its work, and improved partnerships with GPs to share records and therefore enhance treatment. Better communication has been a key thread of what we've been finding out. We worked with the Queen Elizabeth Hospital in King's Lynn to help them enhance the way they communicate with their communities, whether around appointments or future developments at the site. We also contacted all the health trusts with responsibility for Norfolk to find out about the efforts they make to ensure their communications are accessible. The results varied, some doing a lot of work on it already, while others saying there were still improvements to make. Our engagement also revealed there was work to do around translation for those patients who didn't speak English. The NHS is promising all patients better digital access to care by the end of 2024 for those who want it. We asked patients and healthcare professionals about their experiences so far, and the findings included clearer information about the digital systems out there, better promotion of them, and also tidying up the footfall system to make it clearer for those practices who use it. We completed the first 12 months of a 3-year programme to evaluate the transformation of community mental health. 5 different groups of people were engaged with, including adults severely affected by mental illness, their carers and support staff, voluntary organisations and care employees. Among the initial outcomes were people wanting to see greater trust, continuity around their care, and making sure carers are part of these discussions as well so they can give appropriate support. Where things are working well, they need to be communicated better, and there was also a feeling that more involvement in shaping services was needed from the voluntary sector. Ways of preventing people in Norfolk needing health and social care were also investigated. We found a number of ways of helping with this, including the use of technology, more being done in the workplace around health and social care, making sure that messaging from health and social care is consistent and not just about pressures, and also to start prevention work at a young age. People with pressure ulcers and lower leg wounds and their carers took part in a series of interviews to find out about their experiences of care. We found better training and communication was needed, as well as a greater availability of knowledge and information about these conditions. We also evaluated the pilot Waiting Well project, which supports people waiting for orthopaedic surgery in parts of Norfolk, with help like home adaptations, physiotherapy and well-being support. The project got a mixed response, and we suggested more communication about it, including information leaflets and a follow-up process to ensure the Waiting Well support was received. And we worked with patient participation groups to find out what extra help they needed to support practices and help to be their face in the community. A number of recommendations were given to the Norfolk and Waveney ICB, which asked for the study, around extra help, including more communication, recognition of the role of PPGs, and a mechanism for recommendations they make to be taken forward. Our engagement team have been very busy. They've carried out at least 130 visits to GPs, dentists, pharmacies, libraries, community centres and major events to hear about people's experiences of health and social care. Talking to people face to face remains absolutely vital to ensure we're getting rich feedback about the care and support people are getting. The team also carried out a piece of targeted engagement at GP practices, visiting 50 across Norfolk. This gained an idea of the challenges being faced, and we published recommendations to improve things, including shorter waits on phones, the opportunity to share best practice between surgeries, and better communication and information sharing. Our signposting service remained busy as we helped 471 people with information, advice and support if they needed help with any aspect of health and social care. In addition, we received 2,656 reviews on our website about different providers. We also created digital information about a number of different subjects, including the progress of the Shared Care Record scheme, which means people across different hospitals and care settings have access to your information so you don't have to keep repeating yourself. The toolkit for PPGs, fire safety advice, information for carers, and a behind-the-scenes look at a pharmacy to understand the process from prescription to getting medication. The work doesn't stop there. In this new financial year, we've published reports on pharmacy care after visiting dozens across Norfolk, and also the My Views Matter report looking at residential care for people with learning disabilities and autism. Alongside this, we've published initial findings of our 3 hospitals' 3 weeks engagement project, which saw us spending a week at each of our 3 acute hospitals. The Queen Elizabeth and James Paget Hospital reports are now published, with the Norfolk and Norwich one imminent, and an analysis of what we found across all 3 being released later in the autumn. Even though we're anticipating another busy 12 months, we still urge you to leave your feedback with us and share your experiences, face to face, by phone or online. We are here to listen and share your views with those shaping care across health and social care.
So what's coming next? Well, as the video just mentioned, we will be publishing a detailed report about what we found during our 3 hospitals 3 weeks campaign, which will be considered at a high level, as well as already creating a lot of anticipation amongst patients and in fact our friends in the media. We're working closely with carers of those with serious mental illness on an action plan to ensure they're getting the help and support they need. We're working closely with people who have experienced the challenges of caring for their loved ones and those who work at a senior level of health and social care. We really do aim to make real change as we progress. And we've got some exciting work coming up, working on encouraging more young people to get involved with becoming hospital governors. We're working with some budding video producers and presenters to create some online video content, initially for the Queen Elizabeth Hospital, but the James Paget and the NNN, rest assured, will be coming after you soon. What we hope to achieve here is to get further insight on how young people can play a part as volunteers and perhaps employees of the future. The other interesting thing to think about there is the impact that new hospital builds might have on young people and what they might want to see as things move forward. Our ongoing work is continuing around mental health care in the community and ensuring people who can use them are aware of the digital tools that can exist and can assist their care. After 10 years, we felt that the Healthwatch Norfolk website needed refreshing and redesigning. That's been currently worked on now and will go live this autumn with a more streamlined design which will make it easier for people to leave their feedback and get access to the information that they need. And we're going to formally acknowledge those partners who work with us regularly with the new accreditation, so patients know that they're partnering with us to ensure that their feedback is being gathered and listened to. All 3 of our acute hospitals, the surgeries, pharmacies, care settings and other organisations we work with will regularly will receive this recognition. We also want to continue hearing from you, as it's important that you tell us what's working well and what could be improved so we can let the decision makers know. Talking of working with partners, the new Patient Safety Instant Response Framework, or PSIRF for short, is something we all need to be aware of. It's a new way of looking into incidents like slips, trips, or suspected medication mistakes, which ensures patients and their loved ones are at the heart of these inquiries, and that they know exactly what's going on and can be reassured. The phrase, lessons that we have learned, are carried out, and it's not just a media headline, but will happen. We worked with some of the staff at the Queen Elizabeth Hospital in King's Lynn to tell patients about this new system.
The NHS is changing the way it works when it responds to an incident involving patient safety. Patients and their loved ones will be at the heart of this.
Me, I've been on a long journey with this. I worked with NHS England and NHS Improvement as we were thinking about the idea. So it's really great to see the culmination of it. It is about changing the way we do things and making sure we're open, transparent, honest, and a no-blame culture for patients.
PSERF is the new framework that will look at incidents and investigate it, and I think it will mean for the patients that they're a bit more involved in the investigation process and feel like they're a bit more involved in it.
So we're all really excited about PSERF because there's been a real shift in emphasis now onto learning from patient safety events and really knowing what to do with that learning knowledge and improving our care.
It's a big change. It's not limited to just my division. It's going to affect the whole of the trust, every trust, and it's a fresh eye approach to how investigations are actually conducted. Quality and safety is very much at the forefront of what we're trying to achieve, and a fresh eye system-based approach such as PSERF, we hope that that will address the issues that we're facing. The key pillar of change there is a focus on improvement and a focus on compassionate engagement with that patient, but not limited to that patient. That also includes any partners, families, because often they're the second victims.
They get to sort of have that sense that they've been part of the process, and they know that nothing really has been kept from them because they're always informed, so they know that they've had a good impact and good input into the situation.
Yeah, it puts a lot of pressure on nurses to be, because you feel like you're the sole person responsible for your patients. So it's fantastic to know that this is coming in to sort of share the responsibility. Like, it's not just one person, it's the whole team.
Then patients should be front and centre of that. They should be involved in every aspect of it, whether it's the investigation, finding out the various details of what happened, what we can learn, and then how we're going to implement the changes that will help, prevent any future instances from happening again.
There shouldn't be a blame culture within the NHS, really. And learning, because every day is a learning day, so we're always learning and feed that back to patients and staff.
The focus should always be learning from the event, not trying to blame someone. We're all here to develop professionally and personally, even though we're qualified in our field of work. There's always scope for learning, improving.
Looking at compassionately about when things have gone wrong and being respectful and empathetic to everybody involved, and everybody learning from incidences that happen.
It's great to involve everybody, really, because everyone's responsibility at the end of the day, patient safety, patient care.
Prevention is always better than reacting to an issue when it happens. We would like to identify any issues ahead of time so that we can avoid any potential incidents in the future. Prevention is always better than treatment.
It's about listening, acting, and involving.
We have a duty of candour, which we're very proud of, that we take great care in having openness and transparency with our service users and their families to explain what went wrong and to give them answers, which I think is really, really important. But it's about extending that now to a wider stakeholder group and bringing in more people and having experts round the table so that we've got a much more robust, meaningful system.
We will make sure that we have patient representatives from our communities as we're doing investigations or as we're reviewing issues that have occurred, and that will be a huge change for many, many people.
To find out more, log on to www.healthwatchnorfolk.co.uk/PSER.
We'll forgive the consultant for his West Ham lanyard, but actually may I formally thank Alice and her team for all the help that she gave us in working on this particular piece of work. It's now sort of time to come to the main event, really, which is to formally recognise some of the people who have gone the extra mile to help us over our first decade, our Healthwatch heroes. We wanted to say a formal thank you to those people outside our organisation who've worked hard to support us in a variety of ways, whether it's working with us on projects, providing us with vital intelligence and support, and ensuring we can do as much work as we possibly can to help Norfolk's patients and cared for. We had a lot of discussion about who we thought should present these awards and felt that as it marks our first decade, we should ask our first chair, who is someone who continues to support us. Mary Ledyard and myself, Mary is in the room somewhere, I'm sure, yes, she's at the back, basically press-ganged Bill Armstrong, who was just about to retire as the county coroner, to come and work with us. And foolishly, but very much to our delight, he accepted the challenge, especially working with me, who has continued through all these years to support us. Whenever we need his wisdom, support or advice, he's always quick to respond by telephone or email. Our honorary president, Bill Armstrong.
Thank you, Alex. Martin Luther King once said, "Our lives begin to end when we become silent about the things that matter." Well, health and social care, of course, matter. They matter to all of us. They matter to each of us as individuals, matter to our families, our friends and those we care for, and matter also, of course, to the health and well-being of our communities. That's why Healthwatch Norfolk is so important. Important in eliciting views, perspectives and lived experiences from people, assessing and evaluating these in a professional way, and communicating effectively with service providers, with commissioners and policymakers so that they can have, and have had over the last 10 years, a very real impact. That's what we've been doing over the last 10 years at Healthwatch Norfolk, and you're here today, of course, to hear about that, to see what's been going on, and to talk about everything that's been happening over the last 10 years. So much has been achieved, and Healthwatch Norfolk, I think you'll all agree, has become established as an effective, professional, productive organisation, providing a voice, having an impact, and making a real difference. As well as all this, of course, what we should be doing and are doing today is highlighting good practice, commending real achievement, and congratulating and endorsing those who have gone the extra mile and celebrating those who have not only given Healthwatch Norfolk great support, but also made a tremendous impact on people individually, making a difference. So it's a real honour and privilege for me to be invited here today to make these presentations to our Healthwatch heroes. All of them are very special people. All of them have made very special contributions. All of them in a very special way. All of them making a difference.
Firstly, we wanted to say a big thank you to someone who we've worked with very closely during Healthwatch Norfolk's first decade. As the county's Director of Public Health, Dr. Louise Smith has been so important for our work. She's worked behind the scenes tirelessly with us, helping shape our priorities and ensuring we dovetail in what work is being done by public health, while also ensuring we fulfil our core roles of helping patients get access to the information they need when we need to, and indeed holding the system to account. So Louise, there's going to be a short video, and then...
Louise Smith was Director of Public Health for Norfolk from 2015 to early 2023 and felt Healthwatch Norfolk's value was in making sure patients could share their views and experiences.
The whole point of health and social care services is for the people that are receiving them. So having people's voice and hearing about their experiences is absolutely vital to planning and delivering any kind of health or social care service.
This meant working with Healthwatch in a number of different ways.
Firstly, as partners in planning the whole system, we only make services good by working together, and they were an important and representative of service users around the table. And there were some big campaigns that we worked on together. You know, an obvious one from a prevention perspective is getting everybody to have their vaccination. And the comms and hearing the concerns that people have back, allowing us to answer the questions that people had about being vaccinated was a really important part of encouraging everybody to take up the vaccination.
And there were other projects too.
A specific project for us was we asked Healthwatch to look into the health checks services that we offer. So we offer a check for people who think that they're healthy and in middle age, after the age of 40, to look to see if there are any things that they need to do to improve their health and prevent long-term health conditions like heart disease.
Her ongoing knowledge, support and advice meant she was a definite choice for a Healthwatch Hero Award.
It's absolutely lovely, and we worked so hard together, particularly through things like the COVID pandemic. So as a reflection and a memento and a thanks, it's really appreciated by me, but also all the people that I worked with, the public health team, because it really is a team effort.
Dr. Louise Smith.
Louise Smith.
Our next recipient is somebody who I have been known to have the occasional drink with in the north of the county, as she lives in the next village to me, and her sister lives in the same village as me. So Sharon Brooks, we really do need to say thank you. She runs and heads up an independent charity which represents and supports the carers of Norfolk and Waveney. Carers Voice Chief Officer Sharon Brooks.
Sharon Brooks is Chief Officer at Carers Voice. Both Sharon and her team have forged a close working partnership with Healthwatch Norfolk.
For me, Healthwatch is really important as it holds the same values that we have, which are about influencing and creating change by making sure that you have the voice of the user, and so for Healthwatch patients and carers. And we really value the fact that Healthwatch come to us as we have such a knowledge of carers. We're a small organisation, but we have 2,000 members, so we have a wide reach, and we really enjoy working with them. We have the same aspirations, the same goals, and want the same outcomes.
This dual approach, sharing knowledge, expertise and feedback, have been seen through a number of pieces of work.
Two of the most recent examples, and the first one is the engagement report that we prepared for the first all-age carers engagement strategy for Norfolk and Waveney, and we did surveys, we did some research with yourselves, and then we also had Healthwatch facilitate some workshops, which was great, having another independent voice there for the workshops. And the other piece of work that we've been involved in is discharge. Carers came to us saying how difficult discharge is. We know it's a national problem, but we wanted to see what we could do within this area. And we talked to yourselves about the research that's already been done by Healthwatch on discharge and about how we should take the project forward. And then we developed a task and finish group, which is ongoing at the moment.
Hearing from carers is important, but for Carers Voice, that's only the first stage of shaping services and making changes.
It's really important, those key findings, to make sure that they do become outcomes. And in no particular order, it's really key that carers get the right care for the person they're caring for, and that they also access support and know what's available. It's really important that there's continuity of support, and the fragmentation of services was really noted, and together with the lack of communication between services and departments, there's a real importance of carers groups and peer groups and other community networks. And it's really important that the identification and raising awareness of carers and capturing their value is recognised. Carers also told us about the real concerns they had about long-term care planning, and this was particularly important for parent carers with parent carers of all ages. And then obviously mental health was a cross-cutting theme. One of the things that's also come out of this was the discharge work that we've been doing, and we've held workshops on that, and we've distilled it down to concentrating on communication and medication, and that's really important work that we're carrying on with at the moment.
Alongside this, Carers Voice also work hard to share information and advice as well.
We have our locality meetings, so they're based in 5 localities in Norfolk and Waveney, and they take place every quarter, and they deal with a variety of topics. Obviously there's an emphasis on health and social care. We also worked with Healthwatch recently on this serious mental illness campaign and that project, and that's been really important to us, and it's the same similar values as well, and we appreciate the importance of carers that Healthwatch placed on that project and getting the feedback direct from carers. The live events are great. We do some live events ourselves, but we also really value going to other live events. But the other events, such as Live East in Boston, that was a really good event that we really like getting out, being able to meet people on a one-to-one basis and a face-to-face, which has been great after having had so many meetings on Zoom. So we're really proud about having co-produced the work on the Carers Identity Passport. And it's very important now that carers can be identified in healthcare settings. We've had really good support from Healthwatch on this. And now it's being rolled out to GPs, social prescribers, pharmacists, optometrists, dentists, and OTs. So it's really important that the knowledge of the Carers Identity Passport is growing.
This is just a snapshot of the work being done by Sharon and her team. It's this vital support and help to Norfolk's network of carers that helped us decide Sharon should be awarded the title Healthwatch Hero.
I really value getting the award from Healthwatch. It's an organisation that I respect very much. I would like to say though that I think anything I achieve has only been because of the support of the Carers Voice team. We are a small team. We also have 8 amazing carers ambassadors, but anything that I've been able to achieve has been because of the support. We are told that as an organisation we do consistently punch above our weight, and I think really that is only due to the fact that we have such a fantastic team with the carers ambassadors, and I really would like to thank them and accept the award on their behalf. Thank you.
May I introduce Sharon Brooks.
Sharon Brooks is Chief Officer at Carers.
Our next recipient actually can't be here. He's decided he'd rather be on holiday in Spain. And you kind of can't blame him because I think it's about 28 degrees there today. But it's Tony Edwards who volunteered with us to help with the My Views Matter report, which looked into people with learning disabilities and autism, and it was working around the campaign that we did visiting residential settings. As this video shows, his enthusiasm and passion when helping us has been limitless.
Tony Edwards has been a key member of our My Views Matter team. He's been joining us visiting care homes for people with a learning disability or autism and helping draw up a picture of care. Tony first heard about it through About with Friends in Cromer, who helped us design packs to tell residents, their families and carers about the project.
It's on the internet and on their YouTube channel, and I thought it was interesting to learn with my skills and independence to visit care homes and stuff like that, and talking to the residents and the staff members.
Tony's worked closely with Healthwatch Norfolk's John Spall, who heads up My Views Matter and briefs him ahead of each visit, telling him about each area to talk about and supporting Tony while he chats to residents and staff at each site.
So he asks me questions, what I need to say when we get to a visit care home, if the guys who want the service users want to go out or not go out, if they want to do activities in the daytime in the home, if they've got any drivers on.
He's learnt a lot through the process and has really enjoyed being part of the My Views Matter team.
I like going out when it's like being independent, to visit people at homes and that sort of thing.
Tony's also enjoyed giving something back to the community by helping with vital insight and information for the finished reports, which help enhance care for those with learning disabilities and or autism.
It's helping for the residents, the staff members, the support workers to learn their skills, be independent in the future.
This is his ever modest reaction to being named a Healthwatch hero.
Excited to be up with heroes and stuff.
As I said, Tony couldn't be here because he's in Spain with fellow members of the About With Friends Club from Cromer. And our chair, Patrick Peel, in his role as Deputy Lord Lieutenant, handed over the award at a ceremony at About With Friends in Cromer. And his friends and colleagues then had held a celebratory tea party. Our next award goes to two individuals who, when they first approached us to talk about something called liothyronine, not only did I not have a clue what it was, I didn't even know how to pronounce it, but they very kindly coached both Judith Sharp and myself through the vagaries of thyrotoxicosis and various other things related to the thyroid gland. And their endeavour was to actually ensure that people who were entitled and needed certain drugs actually got them. It was something that was what was called double red tagged, which meant that it was virtually, it was like getting into Alcatraz or getting out of Alcatraz in order to get a prescription for it. And ironically, the drug, you could buy 28 tablets for something like £22 in Dublin, or in Cyprus, or in Greece. And it was something like £780 for the same prescription in England. So it was a complete travesty of justice, really. Both Tracy and Tara succeeded in ensuring the people of Norfolk are able now to access this drug. But not only have they done that, they're actually campaigning nationally in order to ensure that every other person who is suffering from this thyroid condition receives an equitable service.
Tracy Howlett and Tara Riddle have been campaigning locally and nationally to ensure patients with hypothyroidism get the best treatment possible for their care.
Well, we are both hypothyroid patients, which means underactive thyroid. I've been diagnosed about 30 years ago. Most people feel well on the first-line treatment for hypothyroidism. The first-line treatment is called levothyroxine, which is known as T4. Most people are fine on that, but there's a significant cohort of people who are not well on it. And if you're not treated well, if you're untreated with hypothyroidism, it can affect most areas of your life, and it affects all your body systems. So it really is quite profound effects sometimes. Brain fog, weight gain, depression, heart problems, high cholesterol, blood sugar problems, all sorts of things. So it's really something that I think a lot of people don't realise how much the thyroid can affect your life, and it seems as though it's going to be easily treated, but it's not always the case.
Tracy was having exactly the same issue.
And I tried to access this medication and was refused it. And I ended up having to, after many years of trying to access this medication, to go private. But the reason that this medication is refused to thyroid patients was because of the pharmaceutical company who was making the medication. It's a thyroid hormone. They were price hiking, and they've since been found guilty of price hiking by the CMA. So patients all over the UK and here in Norfolk just couldn't get access to the medication that they needed to be well. I set up a group because I knew there's other patients like me, and so I set up a group called the Thyroid Support Group Norfolk, or TSGN, which really can be found on Facebook. And as we, through that through that group I met Tara, and together we started our campaign. So we started off very gradually with the help of Healthwatch Norfolk. And the group grew and grew and grew, and we were astonished to find out just how many patients in Norfolk or Norfolk and Waveney area were affected.
Quite soon after our group started, we learned about Healthwatch and went along to the AGM and approached them there, and they showed an interest.
So they helped us sort of navigate the commissioning services, who to speak to. We got a lot of information, a lot of reports together, so we had really good, robust campaign information. But what we really helped us with was to form positive relationships within the local NHS. So we were able to have really good discussions and calm discussions that were really taken on board.
After a lot of meetings, work, research and effort, it's meant a more positive outlook for Norfolk people with hypothyroidism.
Norfolk is great, and patients are reporting that so, now that they are getting T3 and their lives are being changed.
Healthwatch Norfolk wanted to reward both Tracy and Tara for their efforts and make them Healthwatch heroes.
We're just humbled and delighted, really, to accept the award on behalf of the patients that we represent. Because it's not just us. I know we've sort of done the hard work.
But it wasn't just for us. There were so many people out there who need help. We were astounded when we first heard the news, but delighted.
Yeah.
So now we want to push it on a little bit more.
That's where we hope Healthwatch England might even think this is a worthwhile campaign to take up nationally.
Especially as it affects a huge number of people.
Tracy and Tara are both very modest about the amount of work they've done, so it gives me great pleasure to welcome them to the front.
Thank you so much.
You've got to stand and have your photograph taken now. Our next recipient is Kerry Sumner, who has left her role within Norfolk County Council to head up the fire service across Norfolk. Unfortunately, she can't be with us today as she has got other work commitments, but she joined us in our offices a few days ago to receive her award.
Tracy Howlett and Tara.
We're consistent.
Has worked with Healthwatch Norfolk since it began, helping to advise and support the organisation as the County Council's Director of Community Information and Learning, and more recently as Norfolk Fire Service's Chief Fire Officer and Director. This has meant helping with a wide range of the organisation's projects.
Well, it's so far-ranging, the amount of different areas that Healthwatch get involved in, and primarily, of course, they are there to represent the voice of users of health and social care across Norfolk, and particularly to have a voice for those seldom heard groups or groups that might not usually be picked up in terms of looking at requirements and needs for service. So there's that side of things, but also I think the proactive and innovative work Healthwatch have done to take forward information provision, making sure that people are aware of their own health, where they can access services, the signposting side of things. I think they've really made great strides around that.
This has encompassed a wide range of different areas of health and care, and Kerry highlights some of the projects she supported us with and which we helped supply data and feedback to for decision makers.
During the pandemic, the Healthwatch team were incredibly proactive. They joined in some of the wider public sector networks of how do we support our most vulnerable residents, how do we get information to them, and how do we help people make sense of all of the different messages that were out there during that time. and also some really proactive work in to support groups with different language requirements. And again, that carried through when we had our Ukrainian guests coming to live in Norfolk. Healthwatch were one of the first organisations to translate a whole range of health information into Ukrainian and related languages so that people could understand that and access those vital services as they came to the country. But I know there's also been some really fantastic work over the years around looking into the needs of veterans, the needs of disabled service users, and particularly outcomes for looked after children and adopted children are some of the things that spring to mind immediately.
In the last year, Healthwatch Norfolk and Norfolk Fire and Rescue Service have also forged closer links to share and distribute safety information.
I joined Norfolk Fire and Rescue just over a year ago now. A fantastic organisation to be part of. I'm very privileged to have the role of Chief Fire Officer, and realised straight away how we could utilise some of the existing capabilities of Healthwatch, some of the networks to really promote some of the wider messages around safety and wellbeing, again for our more vulnerable residents, those that are more at risk of fire, maybe have mobility issues, that maybe are having care support within the home, and looking at how we could really get those messages out to people and extend our work there. So, really happy to be able to continue that relationship with Healthwatch and utilise the skills and the tools that you have available.
A wide range of work, and Kerry's been a vital bridge between Healthwatch Norfolk and other organisations, ensuring a free flow of data which can, in turn, help enhance and improve services for the people of Norfolk, which is why we named her a Healthwatch hero.
I was surprised and delighted to be named as a Healthwatch hero. Absolutely wasn't expecting it, but very honoured to get the award. Worked with Alex and the team from day one, pretty much, when Healthwatch was set up back in the day, and it's been great to be part of that journey, to see the evolution and to see the strength of Healthwatch nationally, but also the proactive approach taken here in Norfolk.
Thank you. Our final recipient is someone else who has worked with the wider Healthwatch community since its inception, initially in the south of the country and then here in Norfolk when she moved into the county. The Queen Elizabeth Hospital Chief Executive, Alice Webster, has worked with us both ensuring we can gather the views of patients and working with us on specific projects around different areas of patient care.
Alice Webster is formerly Chief Nurse and now Chief Executive of the Queen Elizabeth Hospital in Kings Lynn. She's been associated with Healthwatch for its entire first decade, a third of those in Norfolk, and said she values the partnership.
Having worked with Healthwatch over the last 10 years, but particularly with Healthwatch Norfolk the last nearly 3 years, is the absolute independence. Really understanding that patient voice. As a nurse, that's really, really important to me, and it's important to everything that we do.
So how exactly has Healthwatch Norfolk helped Alice and her team?
On a monthly basis, there's a programme of work. We'll ask you to come and join, come and talk to patients, come and talk to staff, look at a particular area, and really understand what's going on, but then what we can do and how we can make that better.
There've been some longer term projects too. One was focusing on how the hospital could enhance its communication with different West Norfolk communities.
And you did a particularly strong piece of work with the College of West Anglia, where we asked younger members of the community to respond, and you had so many, which was just brilliant, and I have to say has really strengthened our relationship with the College of West Anglia to look at how we bring people into the workplace. I know you also worked with Scope, and again we're looking at how we open opportunities to community to either participate in that patient experience journey or even to come and work with us. We're always happy to do both.
Another saw the QEH piloted for Healthwatch Norfolk's first ever 3 Hospitals 3 Weeks campaign, which saw the entire Healthwatch team gather feedback from across the hospital, which could be analysed.
It's the second first I've done with Healthwatch, if that makes sense, because I did something in East Sussex some years ago. But with this, it really was important for us to be able to understand where we were going and to be able to work with James Paget, Norfolk and Norwich, and really to understand what our patients and public perception of us is. And what was brilliant is you were here at the time when we had the new hospital announcement, which was just fabulous because you have been such an integral part of our journey. It was great to have you on board and we could have picked that week. So yeah, a huge thank you on behalf of all of us at QE and certainly our population of West Norfolk. You do an amazing job and we are so proud to be in partnership with you. Thank you.
And this work has all been achieved through a partnership with Alice at the top, and her support and drive is why she's been announced as a Healthwatch hero.
I'm overwhelmed really, if I was honest. My team could tell you it's not often I'm lost for words, but I think I probably am. I'm really humbled. I do what I do because I want to really, really make a difference to the population that we serve, and to be able to be recognised in this way is just fabulous, but I don't do it on my own, and so I take this on behalf of the whole team. Thank you.
So, Alice Webster. So you'll be pleased to know we're coming to a close, but I just want to thank you all again and all the recipients. If you'd like to see more about their work, there will be some extended videos, including a full report on Tracy and Tara's battle to secure a fair deal for hypothyroidism patients, and they'll be up on the Healthwatch Norfolk YouTube site later. Before we enjoy some lunch, can I say thank you very much to Bill Armstrong for joining us today to present the awards and for his continuing support. I'd like to make additional thanks to Norwich Live Streaming and Saturn AV, who have worked hard today to bring together the technical side of the event, along with the forum team, and to Andy Higgins, who's provided the BSL interpretation for this event today, and also continues to support both us and other Healthwatch around the country to be as accessible as possible. Thank you, Andy. And it would be remiss of me not to actually thank the Healthwatch team and actually all our stakeholder partners. We have our differences, all of us. But the one thing I can assure you all, hand on heart, is that everyone in this room is out for the same outcome, which is to secure better outcomes for patients. It might not seem like that at times, but that really is the case. As a staff complement, Healthwatch total 15 people plus our volunteers and indeed our trustees who we couldn't work without. And they feel they've completed a huge amount of work over the last 12 months, and there's no sign of that pace slackening. Finally, thank you all for coming, and to everyone who's got in touch with us over the last 12 months. Without those experiences, information and support, we could not do what we do. Thank you again for all attending Healthwatch Norfolk Live 2023.